Hi everyone, welcome again to the Borderline Personality Disorder Family and Consumer Education webinar series. My name is Chris Palmer. I'm a psychiatrist here at McLean Hospital. I'm the director of this education initiative, and it's my pleasure to welcome all of you to today's webinar. We are joined today by Rebecca Schulman. She's a clinical social worker in the Dissociative Disorders and Trauma unit here at McLean Hospital. And she's going to be speaking with us on inpatient hospitalization, providing a crash course in treatment of borderline personality disorder. Before we get started, I have a few logistical announcements to make. We do want this webinar to be interactive, and we want to be able to take your questions and answer or give feedback on any cases that you're struggling with, but we do want to maintain your confidentiality. So your identities have been hidden from other participants. If you come to the webinar with a question, or if you have a question while the webinar is going on, you can use the Q&A box in the right lower hand corner of your screen. And if you have come to the webinar with something in mind, you can type it in even now, and we will put it in queue and get through as many of those questions as we can. In the lower left-hand corner of your screen, you'll see links to a lot of websites. These contain a lot of resources on the topic of borderline personality disorder. The first one is our homepage, where you can sign up for upcoming webinars, or you can view archived webinars over the last few years. The next link will be to register for our June 7th webinar. And then the following three are links to national resources on borderline personality disorder. The Borderline Personality Disorder Resource Center in particular is equipped to give referral information around the country, at least here in the United States. For those who are international viewers, unfortunately, I don't have a resource for you. And then finally, the last link is a link to help support these webinars if you're in a position to do so. These webinars were made possible through a philanthropic gift from a family affected by borderline personality disorder. And if you have found them really helpful and packed with information, please think about giving to support these webinars so that we can continue them going on. And with that, I'm going to turn the webinar over to Rebecca Schulman.
Hi everyone, and thank you for joining our webinar today. And like Chris said, my name is Rebecca Schulman. I am a social worker here at McLean Hospital. I work on an inpatient unit for adults, and we primarily treat adults with personality disorders. We work with a lot of individuals who struggle with borderline personality disorder. We also work with folks with trauma disorders, so PTSD, other trauma-related disorders, dissociative disorders. And we also are specialized in working with folks with mood disorders, anxiety disorders. So just wanted to give you a little bit of a blurb on who I am and the perspectives that come with to this webinar. So we are going to get started, and when I was asked to host this webinar, well, my initial thought was, oh my gosh, I'm going to be so nervous in front of a camera. But my second thought was, great, I can actually shed some light on what an inpatient hospital experience is like. I get a lot of questions from individuals who have never been hospitalized before, from family members, about what happens behind the locked doors of an inpatient unit. And one of my aims today is to try and dispel any fears, any concerns that people have about an inpatient setting. And the reason I open with this statement is because, interestingly enough, when I was preparing for this webinar, I was working with an individual on the inpatient unit, and she said to me probably midway through the hospitalization, Rebecca, I had no idea this is what an inpatient experience was like. And what did you think it was like? And she said, I have always thought that if I ever saw a hospitalization, if I ever saw treatment in an inpatient setting, it would be me going to this locked unit, this isolating cell where I would just feel like I was locked away. And she said this was so much more therapeutic and supportive and just really helped me get my life back on track. This just happened about a week ago, and I was like, well, maybe I should focus a little bit more on what we are, what an inpatient setting is like. So with that in mind, let me try and guide you through a crash course in the inpatient setting for BPD. So what we're going to focus on today are a couple of things. We're going to discuss what borderline personality disorder is briefly. I know other webinars have gone into more detail on what the diagnosis is and what the treatments are, but I think it makes sense for all of us just to be on the same page regarding what we're talking about, specifically because we're going to be speaking about inpatient skills and treatment and how that aligns with some of the presenting problems people come in with to the inpatient setting. We are also going to speak about treatment recommendations and aftercare planning, and then we'll talk a little bit about just what the experience of an inpatient setting is like. All right, so again, we're not going to go into a lot of detail on what borderline personality disorder is, but just so we're all on the same page, let me just briefly summarize. So a personality disorder is it's a disorder where people have pervasive impairments in personality, so in their self, in their interpersonal relationships, functioning, and there's presence of pathological personality traits. So I've listed the criteria for BPD. I've summarized it a bit from the DSM. So I just want people to have this in mind as we talk about what the treatments are and what the aftercare plans are for folks who struggle with these symptoms. So in brief, folks with BPD also often have unstable interpersonal relationships, self-image, affect, and marked impulsivity, which can also include safety concerns such as suicidality and self-harm behavior. So what does BPD look like in the community? So in the general population, about 1 to 3% of individuals meet diagnostic criteria for borderline personality disorder. And that's a significant amount when you think about general population. 3% of people have this disorder. With that in mind, think about this statistic. So inpatient hospitalizations, up to about a quarter of individuals at a time may meet criteria for borderline personality disorder. I came across that data and I was like, this is a staggering amount of people. And some studies will actually even say, closer to 40% at times will meet criteria for this diagnosis. So what does that say to us? That individuals with borderline personality disorder utilize inpatient services quite frequently, or emergency services. So I just want people to keep that in mind because this is a disorder where a lot of folks will utilize, urgent care settings, ER visits, inpatient settings, and there's a high recidivism rate, meaning people are rehospitalized quite often with this disorder. The other thing to think about is that there's a high comorbidity when it comes to working with folks with borderline personality disorder, meaning that people with borderline personality disorder may meet criteria for other diagnoses. This could be other personality disorders, and then often folks with BPD might meet criteria for a mood disorder, substance abuse disorder, eating disorder. So I want folks to have that in mind as we go through some of this data, because some of the reasons why people might present to an inpatient setting may be because of these comorbid diagnoses. All right, so what is an inpatient hospitalization? So the criteria to be hospitalized in an inpatient setting is, and when I talk about an inpatient setting, I am speaking about the typical insurance-based inpatient setting. We'll talk a little bit more about maybe a private pay setting in a couple of slides, but for the purposes of this slide and for the overall webinar, we are primarily focusing on inpatient settings that are insurance-based. So folks have to meet diagnostic criteria to be inpatient hospitalized. They need to be struggling with acute symptoms. So when we think about a personality disorder, I mean, these are pervasive symptoms that people struggle with for long periods of time. What often brings folks to be hospitalized on the inpatient unit are the acute symptoms. And by acute symptoms, I mean acute symptoms in safety, so significant immediate safety concerns, whether that be safety within oneself or towards others. So if someone is having acute suicidal thinking with a plan, with an intent, if someone's made a suicide attempt, if someone is really struggling with intense, significant self-harm behavior, if someone is deemed a risk to hurt someone else, if there's safety concerns with other people. The other criteria is, sometimes people will just really not be able to function outside of the hospital setting. And by this I mean they just may not be doing the daily tasks of eating, drinking, completing their ADLs, like really just functioning as people. Sometimes people will need a higher level of care if they have had if they've had a lot of difficulty stabilizing at lower levels of care, and we'll talk about what those are in a minute, but essentially if someone is at an outpatient level or a residential level, a partial level, and their symptoms and their stability really and their safety cannot be managed at that level, they may be what I call stepped up to an inpatient level. People can also be hospitalized for complicated medical and medication evaluations. And so this could also be for ECT services, electric convulsive therapy, for TMS services. So these are all things to think about when you think of the criteria for someone being hospitalized. What is the structure of an inpatient setting? So again, we're talking about the typical insurance-based inpatient setting. So the average length of stay for an individual is about a week, about 5 to 7 days. When we think of an inpatient setting, what I want to relay to you is that this is a locked setting, so people cannot come and go as they please. This is a locked setting with 24-hour staffing. It's a milieu, so it's a community, it's an environment. There's groups, there's mental health workers, there's check-ins, there's nursing staff. People will speak to one another. There'll be a lot of peer support. There's individual work, and we'll talk more about that. There's a treatment team. So the primary treatment team for an individual on an inpatient unit will typically consist of a social worker, psychologist, case manager, and then a psychiatrist, a nurse practitioner, someone to prescribe medication. There's more staffing than just that primary team. There's nurses, there's mental health workers, group therapists, nutritionists, spiritual consultants, probably forgetting some other people, but there's a lot of folks who really help with an individual's inpatient hospitalization. And then there's a treatment plan, and we'll talk more about what an individualized treatment plan looks like. Essentially, a treatment plan is something that is reviewed with the individual and the team and is followed during an inpatient hospitalization, whether it be for medication management, skills, aftercare planning, structuring their days, that sort of thing. All right, so how does one get to an inpatient hospitalization? So there's a couple of ways people can be hospitalized. I think the most frequent ways of being hospitalized in an inpatient unit are to come through an outpatient referral or an ER or an urgent care setting. So someone in the community, so the individual will be seen by someone in the community who feels like they need inpatient level of care and needs more support and structure. And what will happen is there'll be a bed surge, there'll be referrals, and eventually people will end up on an inpatient unit if they meet criteria for inpatient services. There's other ways of being hospitalized. Sometimes people can self-present, and this can be a challenge for a variety of ways, for a variety of reasons. One is that sometimes there just aren't beds available, and an individual might really be in crisis and really be struggling, and so my recommendation is that they speak with their outpatient team or a PCP or an urgent care ER setting and really think about, or really speak with them about what they need, and they'll help with that bed search and getting people hospitalized. I think it's also really important for an individual, especially an individual with BPD, to be on board with a inpatient hospitalization. So I think it really needs to be a joint decision. And so having an outpatient team on board with this decision can be really helpful. During an inpatient hospitalization, the treatment team will often contact outpatient treaters to think about what their thoughts are regarding the patient's safety and stability and what they think is needed for this patient to feel safe and stable at the time of discharge. So I strongly encourage individuals to speak with their outpatient treaters about the decision to be hospitalized. A couple of other terms I just want to throw out there for folks to know, because it is something that comes up on an inpatient setting. So there's a couple of different statuses that people can have when they're on an inpatient setting. One is they can be what's called conditional voluntary. And what that means is that the individual agrees to be hospitalized, is understanding of the hospitalization, is pretty much on board with being on the inpatient unit. There's another status called being involuntarily hospitalized, and what that means is essentially someone is being hospitalized against their will. And that comes up if this individual has been seen by, outpatient treaters or emergency services, and they feel strongly like this person needs to be inpatient because they have acute safety risks and they need to be stabilized. And we won't get into all of the legal stuff behind a Section 12, which is an involuntary hospitalization or a commitment. But essentially what that is an individual can be held for 3 business days, and then they can be discharged within the 3 business days if the team feels like they are safe and stable to discharge. But by the end of 3 business days, they either need to be discharged or the team needs to go for what's called commitment, which is a whole legal proceeding to get the person committed to an inpatient setting. There's also something called a 3-day notice. So what a 3-day notice is a document that a patient will sign who comes in voluntarily. And that patient is essentially saying by signing that document that they want to be discharged within 3 business days. So it kind of starts the clock running, and then the treatment team and the individual have to work on trying to stabilize that individual within 3 business days or go for commitment. So it's a little similar to a Section 12, but if people have questions about that, I can try and answer it. I'm not going to go into all the legal stuff behind those situations. So what happens on an inpatient unit in terms of treatment? So, an inpatient unit consists of individual treatment, so meeting with a treatment team every day and really working with their treaters on the outlined treatment goals. So working on skills, working on containment strategy, safety planning, working on medication evaluation, stabilization, and thinking about discharge planning and aftercare plans. There's also a significant group component to an inpatient hospitalization. So I can speak to what our hospitalization looks like here at McLean on the unit I work on. Skills groups are essentially most of the afternoon from 11 to about 4:30. And those can consist of EBT groups, CBT groups, self-assessment groups, self-care groups, different types of support groups. So there's a significant group component to a inpatient hospitalization. There's also the milieu. I mean, really being able to speak with individuals who might be struggling with similar issues and trying to gain some insight into what's been helpful for them and really try and have some peer support on the unit. One of the questions that I will often ask early on in the first meeting is asking the individual what happened, what precipitated this hospitalization. So thinking with them about what shifted to make them feel like they could not be safe and stable outside of an inpatient setting. And there's ways of doing some work around that. We'll talk about like a chain analysis in a little bit, but essentially having them start thinking about what led me to the point of feeling like I was in crisis, that I needed to come into the hospital. Once we really think that through with an individual, it's thinking about, a safety assessment and how to stabilize this individual. And when it comes to folks with borderline personality disorder, I think this type of work is heavily influenced on skills building and skills and trying to model skills and practice skills with an individual. Now, when I say skills, what I'm saying is time-limited work on specific skills for that individual. We're not opening up Marshall Linehan's book and going through each module for DBT, for instance. We're really looking at what this patient needs in the moment to stabilize, to feel safe, and to feel like they can commit to a life outside of the hospital that is worth living, that is safe, that is stable. Some other things that happen in terms of treatment on an inpatient setting is, like I said, medication evaluation and management. Sometimes folks will be assessed for ECT or TMS, which is, I think I mentioned, transmagnetic stimulation. We also, on the inpatient unit, teams will strongly encourage the individual to sign releases so that we can have collateral contact with their outpatient treaters, with their families, with their support, so that we can have more of a sense of who they are outside of the hospital, what their concerns may be about different safety concerns, different issues that were going on prior to the hospital, and also have people be on board with, discharge and aftercare planning. So just keeping families, keeping treatment teams up to date is really important. The other thing we think about is discharge and aftercare planning. So thinking about a step-down plan, thinking about aftercare plans and what that looks like. I'm just briefly going to review longer-term hospitalizations. It's not the focus of this webinar, and it's not the norm, but I do want to mention it because there are longer-term hospitalizations that happen. So if someone is hospitalized on an inpatient unit that is insurance-based, there's a couple of reasons why someone may be outside of that 5 to 7 days of typical inpatient hospitalization. Sometimes folks might be having a treatment or a medication change that takes longer than that typical week, maybe ECT. The other reason people might be in the hospital for longer than that period of time is if they really are struggling to stabilize and to make a commitment to being safe outside of the hospital. They may need a little bit more time to work on that. And then the other thing I wanted to mention is that there are inpatient hospitalizations out there that are longer term, and they're structured as longer term programs. These programs, if they're insurance-based, which is rare, and if they are insurance-based, there can often be a long wait list to get into these programs, can be more specialized to what that individual is working on. So for someone with borderline personality disorder, they may go to a longer-term unit that specializes in mentalization-based treatment or DBT treatment, and it might be formatted in a way that they stay there for a month, 2 months, and they do a solid piece of work that is specialized for borderline personality disorder. Often these are not insurance-based programs. There are programs out there that are private pay. And we're not going to go into all of that, but I just want to make sure that people are aware that those do exist, and it's a little bit of a different, it's much different format than a short-term structured inpatient insurance-based program. Sometimes, even though these are private pay programs, they may be cost-effective if someone has been really struggling at different levels of, lower levels of care for a while. I mean, that can be costly. There can be, co-pays. There can be other costs associated with that. And so it is something to think about and for families to consider if it's something that is manageable financially. All right, so we're going to talk about why not to hospitalize and why to hospitalize individuals with borderline personality disorder. And I just want to just start off by saying there's no empirical consensus regarding this question, meaning that there are some clinicians out there who are strongly opposed to hospitalizing folks with borderline personality disorder. And we'll talk about some of those concerns, some of those reasons. And then there's individuals out there that actually say, you know what, there is a time and a place for a hospitalization for someone with borderline personality disorder, and there is some specific treatment that can be worked on while they're inpatient. So why not to hospitalize? Some clinicians have concern that this might be a place where individuals with borderline personality disorder can regress. There may be negative effects, iatrogenic effects to being inpatient, and we'll talk about that in a little bit. And it might be a place that they are going to avoid to escape a certain stressor in their life. So that's one view of why not to hospitalize. An inpatient setting is often an emotionally intense environment. So people are there because they are in crisis, and it can sometimes be chaotic. And sometimes that can be a real struggle for folks who already at baseline struggle with emotional stability and emotional regulation. Sometimes folks can become more dependent because the inpatient setting is such a structured environment where their meds are given to them at certain times, their meals are given to them. They have reminders about groups and structure and walks and visits. I mean, it's an artificial environment, and so sometimes folks can become more dependent on that type of structure, which can be really difficult to transition back into the real world once they're discharged from the hospital. Some individuals with borderline personality disorder struggle with some paranoia, right? So sometimes folks will struggle with transient psychotic symptoms that have borderline personality disorder, and they might become more paranoid. They might really not like being locked up. They might not like, having treatment teams meet about them and talk about them in rounds. I mean, there's this whole slew of things that can come up around that. We also have to think about what kind of improvement can happen at 1 week, which is the average length of stay. So we'll talk about what can happen in that period of time. But if someone is looking for a long-term hospitalization to do some really intense skills work, an inpatient setting isn't going to meet those needs. And we also just want to remember that an inpatient setting is an acute focus. So an inpatient setting is not a place where folks will establish like a new trajectory in treatment. It's not just doing a whole reset on their therapy or their life outside the hospital. It's really looking more at troubleshooting some of the things that weren't working when someone was outside of the hospital setting and what led them to come into the hospital. A couple other reasons why not to hospitalize. So I just also wanted to include that there's been, over the last couple of decades, a significant shift in the culture of mental health treatment, and people are not hospitalized for weeks and months, years at a time, typically. So we are shifting to a more acute focus in inpatient hospitalization. The other thing to note is that there are many effective evidence-based outpatient treatments for folks with borderline personality disorder. Some of these treatments I know have been reviewed in previous webinars. So we think about DBT, the dialectic behavioral therapy. We think about mentalization-based treatment. We think about Stigma-focused treatment, transference-focused therapy, good psychiatric management. There's a lot of evidence-based outpatient treatment for folks who struggle with borderline personality disorder, and that type of a treatment will not be something that can happen on a short-term inpatient hospitalization. There's also alternative levels of care for individuals, and we'll talk about that when we start thinking about discharge planning and aftercare planning. But those might be different levels of care that an individual can work through some of these issues, and they don't need to have the structure of an inpatient unit. They can still live their life outside of the hospital with some additional support through some of these levels of care. The other thing to think about is, folks with borderline personality. I mean, what does Marshall Linehan say? You need to commit to a life worth living. Coming into an inpatient setting disrupts someone's life. So, if they're in school, they have to come in, take a period of time off of their academics. Sometimes individuals have to leave work. Sometimes they have this big disruption to their family. Excuse me. So we also want to be thinking about a balance. What are they leaving in order to come into the inpatient setting, and is there a way of them being able to manage outside of a locked unit and continue to live their life and build meaning to their life? The other thing to think about is skills use, coaching. I mean, these are things that can be done in an outpatient setting that may not be able to be done on an inpatient setting. Excuse me. All right, so why to hospitalize individuals? So, of course, there are times and places for people to be hospitalized. If someone is struggling with persistent, severe, acute safety concerns, such as intense suicidal ideation with a plan, with an intent, if someone recently made a suicide attempt, if someone is significantly self-harming, self-destructive, if someone is a threat towards others, these are all reasons why someone may consider coming into an inpatient setting. We certainly, want people to be able to go someplace to maintain their safety. So an inpatient setting may be something that needs to happen for a period of time to get someone to be safe and stable enough to be outside of the inpatient doors. Sometimes people have transient psychotic symptoms. We talked about that a little bit already, and they may need to come into the inpatient setting to stabilize for a period of time. There may be significant impairment, energy compensation, daily functioning. We talked about that. Sometimes folks come in because of comorbid disorders, so substance use. Maybe they need to come in for a detox, and then they do a piece of work to stabilize on an inpatient psychiatric unit. Sometimes people will come in with severe eating disorders and need to stabilize, and there are inpatient psychiatric units out there that may specialize more in like an eating disorder, a dual diagnosis program, or substance abuse dual diagnosis program, that sort of thing. People might just have refractory symptoms that really has been a struggle for them to manage in an outpatient setting or a lower level of care, and they need to come in to do a piece of structured work on an inpatient unit. Complex medical assessments, we talked about that as well. Sometimes people are admitted to an inpatient unit for structure. I mean, containment of intolerable feelings, emotions, impulses, trying to break the cycle of some of these chronic safety issues that might occur on an outpatient basis. Sometimes a crisis will happen and an individual and their treatment team feel like an inpatient hospitalization is necessary to tweak a treatment plan, to really think about what needs to be different for them to be stable and safe outside of an inpatient setting. The other thing I just want to note is that a hospitalization is not a punishment, right? So this is something that I think is important to discuss with a loved one, with an individual that is really struggling, that needs to come inpatient, because I've worked with a lot of folks that have a lot of shame around being hospitalized, and I think it's really important for them to know that a hospitalization is a place where people are admitted to do a piece of work and to feel safe and to develop a plan so that they can manage their life outside of the hospital. And we talked about a hospitalization, especially for individuals with borderline personality disorder, being a joint decision, all right, to keep that alliance, whether it's an alliance with a family member or a treatment team, to make sure that people are on board with what needs to happen, what needs to be different, and what level of care may be the next step for them. So goals of an inpatient setting. So the other question I ask when someone is admitted during my first meeting with an individual is, what do you want to focus on? What do you want to have be different by the time you leave the inpatient unit? Trying to help an individual really think about what they need to have in place, whether it be some skills, some structure, some different levels of support, tweaks to their medication. I mean, what do they feel like they need in order to be safe and stable to leave the hospital setting? The other thing to think about is, educating someone on diagnostic traits. And I say traits instead of clinical diagnosis because when it comes to working with individuals with personality disorders, it's often difficult for a treatment team on an inpatient unit to make that diagnosis. A personality disorder is a pervasive disorder that is there's patterns of behavior that are seen over a period of time in different environments. And what an inpatient team is seeing is a snapshot of that individual's life. It's a snapshot that is usually a crisis situation. So sometimes people come in with a diagnosis of borderline personality disorder. Sometimes people don't. And sometimes people are struggling with some of the traits. And so what inpatient hospitalizations try to help the individual understand is what they're dealing with and try and educate them on some of the symptoms and the experiences they're having. Sometimes I'll sit with an individual and I'll literally take out the DSM and I'll sit with them and say, what fits? Does this fit for you? Is this what you're struggling with? And help them to understand that what they're dealing with is treatable. And to help educate them more on what's going on for them. Because some people come into the hospital and it's like they have no idea and they are so panicked that something is wrong with them. And so giving them words, giving them some education on what's going on, go a long way. So I am also often asked by an individual or by an individual's family, how can they feel better? How can they get to a place of being able to live life outside of a hospital and feel safe and feel stable? And we'll talk about what we focus on: safety, functioning, acute symptom stabilization through the use of skills, meds, treatment planning, aftercare planning. And we'll talk about aftercare options. So thinking about safety. This is I'd say a standard safety plan that you're looking at on your screen. I use a little bit of a different template, but and I'll talk about that in a second. But essentially, it's a safety plan that helps an individual think about the warning signs that they experience, any patterns of behavior that have led to unsafe or impulsive decisions in the past. Thinking about what types of coping strategies they can use. What is their plan? What can they use when they're in distress? Who can they contact? Where can they go? Where is a safe place to go? Can they call a crisis hotline? Can they call 911? Can they call their therapist, skills coach? it's usually a one-page document that someone can have on hand so that they have a plan for when things become unsafe and they feel like they're unable to manage their safety outside of an inpatient setting. On an inpatient unit, just to briefly go through this, I mean, there is a daily evaluation of safety. So thinking about their risks, thinking about their history of safety concerns. Has this individual made a suicide attempt in the past? If so, how? Did they reach out for help? Do they have protective factors in their life? Do they have reasons why they want to be alive? Are they forward-thinking about things in their life? We also work with individuals on deepening their commitment to these safety controls that they have, developing a crisis plan like this, developing a safety plan. How can they be safe enough to be outside of an inpatient setting? I like to use imagery a lot with my clients, and if someone is really struggling with persistent, with chronic suicidal ideation, working with them to put that suicidal thought aside, put it on the back burner so it's not what they're focusing in on all the time. I mean, that can be exhausting. And how can they put that off to the side so that they can focus on skills, focus on a life worth living? So I use a lot of imagery when I work with individuals that are chronically suicidal. We also think about urges to self-harm, thoughts of harming others, sometimes violence, domestic violence, and we can tweak some of those plans if there are issues with violence involved in the individual's discharge plan, like a DV safety plan. A domestic violence safety plan may be a little bit different. The other thing that I have included on the safety plan I use is, what would this individual say to someone who's struggling with similar issues? Really have them take a step back and say, okay, what would I say to a friend or to a family member that's struggling with this? Just have them think about what can they do to maintain their safety outside of the hospital. Here's a chain analysis. So I'm sure some of you have seen this before. I wanted to include this because this is something that I think is often used on an inpatient setting, especially for folks with borderline personality disorder. So having someone look at a problem behavior, maybe a behavior that happened prior to them coming into the hospital, and help them be curious about what their vulnerability factors were, right? So what might have made them more vulnerable to actually acting on that problem behavior? What were some of the prompting events? And by vulnerability, I mean, for example, like, have they just not been sleeping well? Have they been drinking more? Have they not been taking their meds? Have they been not going to their appointments? I mean, what put them in a state of being less prepared to manage a crisis situation? Thinking through some of the links that happened when they were struggling with this problem behavior. So what were they thinking? What were they doing? What were they feeling? What were some of the environmental stressors happening at that time? And then having them think about the consequences. So short-term consequences, long-term consequences. A chain analysis is a non-judgmental way of looking at how a behavior happened and thinking about what could be different in the future going forward. Some other skills that are often used on an inpatient setting may be something like a self-assessment measure. So I kind of describe this as a mini diary card. Self-assessment measures have someone look at their thoughts, their behaviors, their body sensations, their environmental stressors a couple times a day and kind of jot down what's going on for them, how intense it is, rate it on an intensity scale. Use a skill and then re-rate it. And the reason I wanted to show you what this type of assessment looks like is because I find that this is something that individuals can complete themselves and sort of carry with them through the hospitalization and recognize patterns that are happening. And also recognize what skills may work more effectively than others. So I bring up the self-assessment just as a tool that is often used on the patient unit. Group treatment is also key. I mean, this is where there's that crash course in DBT skills, in maybe grounding strategies and self-care. The other things that might be used are more kind of DBT-based treatment, so like working on a Dear Man when you prepare for a family or a team meeting, committing to self-care, building a toolbox of all of these skills. So I could go on and on forever about skills work, but I'm just pointing out a couple key skills that are often used when someone comes inpatient. So coping strategies and crisis management. So we sort of went through some of the DBT skills that may be used and grounding strategies. The other thing that I will focus on with individuals that I think is helpful is what's called a cope ahead plan. Thinking about when they leave the hospital, is there something they need to prepare for that may be stressful? Is there a situation coming up that they feel really like they need to develop some skills around on how to manage this? So thinking about what's going to happen when they leave and how they can prepare a plan to manage so that they can remain safe and stable. The other thing that I'm going to just show you is a chart, and this is called a coping crisis plan, and I apologize, it might be hard to read. This is a plan that actually was created by a former colleague of mine, and I find it to be one of the most useful tools that we utilize in our unit. Essentially what it is in the upper left-hand corner is a self-assessment of levels of distress. So having an individual sit down and think about what are their red flag behaviors, what are their negative thoughts, what are their body sensations, and what are their emotions, and really work with them on rating that from 1 to 10. And then on the flip side, thinking about what are the interventions that can be used when someone is feeling, thinking, doing certain things. So I bring this up because I'm sure other units have different formats, but I think having someone develop a plan that includes coping skills and includes levels of distress is very important, because then they feel more equipped, they are more equipped to manage these different levels of distress when they leave the hospital. I frequently hear from folks with borderline personality, Rebecca, I feel like I go from 0 to 60. And so what this helps an individual to do is really break that down. So maybe they go 0 to 20, and then they're able to really do a skill and manage that so that they're not going from mild to crisis all of the time. We also think about we also work with folks on psychoed, so I touched on this a little bit. I mean, thinking about the diagnosis, working with them to understand what's going on, and giving them, some skills to manage what's going on, validating their experience, clarifying diagnostic traits, and then I include destigmatizing stigma. It's actually a group that we run on our unit, and I think it's really helpful to work with an individual regarding stigma they may feel from the outside world as well as maybe within. Just feeling like I'm someone with mental illness, that means I am flawed, that means I can't do anything in the world. I mean, really trying to remove some of those stigmas and have them understand that mental illness does not discriminate. Family and team meetings. I'm going to try to run through this quickly so we have some time for questions. So the take-home point from this slide is I want people to understand the purpose of a family meeting or a team meeting with outpatient treaters. This is not family therapy. So this is not long-term family work. This is working with a family or outpatient treatment team on an acute issue, on the issue that brings someone to a hospitalization. Maybe there was a conflict in a family that someone reacted to, and so, someone had an argument with their mother, they self-harmed, their mother said, I feel manipulated that you self-harmed, and then the individual feels misunderstood. So if we look at that dynamic, what a family meeting can do is help everyone take a step back, communicate about what happened, and kind of clarify what happened and come up with a plan. So if some of those issues happen in the future, they're well equipped to manage them in a safe and stable manner. We also talk about, what the treatment plan is. We talk about discharge. We talk about aftercare. Aftercare planning. So like I said, collaboration with teams and with families. I just want everyone to know what I mean by aftercare and other levels of care. So there's residential programs, partial programs, which are day programs, but an individual will sleep at home. There's intensive outpatient programs, which are sort of mini partials. They happen a couple days a week for a couple of hours. And there's outpatient treatment and groups, things like that. So these are different levels of care that someone can either step down to when they leave an inpatient setting for additional support and structure, or someone could actually be stepped up from these levels of care if they need the support and structure of an inpatient setting. Discharge planning. So this is a copy of one of the pages out of a transition to home plan that we often use on our unit, and it's working with an individual to think about the transition out of the hospital. What questions should they be thinking about before they leave? What have they learned? What are some early warning signs of a setback? What are they going to say to their families, to their work, to their schools about their inpatient hospitalization? How will they create balance, and how will they manage outpatient treatment and go to school? And then scheduling appointments, so more logistical concerns. So the first page here that might be a little bit blurry for everyone to see is just having them really set up some appointments so that when they leave the hospital, they're prepared with a structured aftercare plan. That may be it. Oh yeah, next step, committing to a life worth living. So I thought I'd end on a high note there and see if there's any questions.
Great. Thank you. Thank you very much, Rebecca. That was a great presentation. I'm wondering, can you talk a little bit about the destigmatizing stigma group that you mentioned it briefly, but can you talk a little bit more about how to think about the stigma of a hospitalization and how people can, what are some of the tools or ways to think about it that can be helpful?
Absolutely. This is a very popular group on our unit. So the destigmatizing stigma group is a group that helps individuals to kind of share, well, first off, it helps individuals have a place to share some of the stigmas they've experienced regarding mental illness. So I think just off the bat, it's a way of having people sort of name what they've experienced and feel a connection to others in the room regarding the stigmas that they've heard, they've experienced in their life. So I think it can be very supportive in that way and very validating for individuals. And then it's thinking more about, like, what is mental illness? And, thinking about ways that individuals can actually advocate for themselves and advocate to people that may be not struggling with similar mental illness about how they can, be productive members of society with a life worth living. I mean, it's really an area where people can come together and think about the ways in which they cope with their mental illness and the ways in which they are able to overcome some of these negative stigmas about borderline personality disorder, about depression, about anxiety. As I said before, mental illness does not discriminate. I work with individuals from all walks of life, all levels of education, all levels of functioning. And so I think, it's something where a lot of people can come together and really think about, like, wow, I have struggled with this, and this is my resiliency, and this is how I've overcome, and really challenge some of those stigmas. And think about ways to advocate for that outside of an inpatient setting as well. There's a lot of advocacy groups that people will latch onto. Good question.
Great. One point I just wanted to make is that you had talked a little bit about the hospitalization and some of the legal some of the legal requirements and or rules, regulations. And I just wanted to make the point that that's from Massachusetts.
Oh, yes.
And we have people viewing from all over the world,
yes.
and certainly all over the United States. So for those in the United States, the laws do vary state by state.
They do.
So the 3-day notice and even the distinctions of voluntary, involuntary can vary, and then certainly people from other countries can have widely varying rules and regulations around hospitalization. So I just wanted to...
Good point.
Just wanted to make that point.
That was in my notes. I forgot to mention that.
One other point that I wanted to bring up that you didn't overtly touch on, it's something that I know from a lot of the literature on suicide risk. But I wanted to point out to the viewers that one of the highest risk times for people to attempt suicide or actually complete suicide is actually the week or two right after hospitalization.
Yes.
And I'm wondering if you could talk maybe just a little bit about what you as an inpatient provider do given that fact, and how do you talk about that with patients and family members, and what, if any, strategies are available to try to mitigate that risk?
Yeah, no, absolutely. Good point. A very important point. So we focus a lot in the inpatient setting on preparing someone to discharge out of the locked unit. And like Chris is saying, one of the most vulnerable times for people, is after a hospitalization, one of the most at-risk times, I should say, for suicide. So really working with an individual early on in an inpatient setting to help them think through some of what they're going to have to manage outside of the locked unit. So clearly there were stressors that brought them into the hospital that made them meet level of care. And so some of those stressors, probably most of those stressors, will be there when they leave the inpatient setting. So I think it is very important, it is crucial to do a focused work on safety planning, crisis management, and setting up structure and support for an individual leaving an inpatient unit. And also to communicate all of this to the individual family, if they're going home to live with the family, other support systems, outpatient treatment. And we didn't speak a lot about some of the step-down programs, but stepping down to a residential program, stepping down to a partial program, stepping down to an individual intensive outpatient program, having maybe more therapy sessions for when someone leaves the hospital setting, giving the individual crisis management tools, so a crisis hotline, suicide hotline, really working with the patient so that they understand what is available for them and what can be done in a crisis situation. The coping and crisis plan I also spoke to you about is something that can be used, and really, I really strongly encourage people to develop a type of plan similar to that, so that when they start feeling like they're at a 6 or a 7 out of 10, they have a plan in place so that they don't reach crisis, especially after an inpatient hospitalization. So I think structure, I think support, resources they can access in times of crisis and distress, really working with them on their commitment to safety, deepening their commitment to safety, and providing support are really important.
And finally, I won't read all of it, but one of our viewers talks about some of the frustration and some experiences with inpatient treatment teams that maybe aren't so ideal. What happens when your child gets hospitalized and the treaters won't even talk to the family members. They are too busy to contact the outpatient treatment team. They want to avoid the borderline personality disorder diagnosis. And I just want to put out there, sometimes they actually do that for insurance reasons. Insurance often won't approve a hospitalization for the diagnosis of borderline personality disorder alone. Instead, it has to be for major depression with borderline personality or something else. There's got to be something else. And given a lot of those frustrations from people, do you have ideas or suggestions for how families or patients themselves can be better advocates?
Absolutely. So I think the first thing that I didn't really touch on is that if someone, and this might also just be in the U.S., but if someone is over the age of 18, if they're an adult, there needs to be a release of information in place in order for the individual's treatment team to be in touch with a family member, with outpatient treaters. There may be some exceptions that I won't get into, but I guess that's the first thing to ask your child, your loved one is, are you okay with me being in touch with your inpatient treatment team? Are you okay with us communicating? And I think it sounds like the question is more of like if the inpatient treatment team is not including you, if you feel like you've asked for support and you're just not getting that. That's a tricky question. I'm sorry that's the case. And, I think that my recommendation would be for the family or the individual, the client, to speak with the treatment team, or if the family can't get in touch, leave a voicemail with the treatment team, and really relay to the treatment team the concerns that you have and the reasons why you feel like it would be helpful to be in touch regarding your loved one's treatment. And for the individual to also say that to the inpatient treatment team, I really think that my parents, that my family needs to be involved because they are major support. Maybe they're a major source of stress, too. I mean, we really need to have them involved because this is something that really affects me and on the outpatient setting. And, I think that just being very vocal and being very clear about what is needed and what your expectations are is what I would recommend doing.
Great. No, thank you. So thank you very much, Rebecca. This has been a great webinar, and we've got to end for today. I want to remind people you can sign up for our next webinar Thursday, June 7th. You see it in front of you.